informed practice. So what ways in the hospitals can you think of that nurses do this? So your current practices, your guidelines, everything should it remain the same from the 1950s to now? It emerges, right? Things get better. It should get better.
I mean, if you're in a facility, usually you go to their standards that they use first. I mean, you'll still learn stuff as you go on, and then the clinic or the hospital will change its practices. But it's I mean, that's what they're teaching us.
And do they still do the clinical ladder? So the quality, the QI projects at the hospital, nurses have to do those.
Yeah.
So, and that is the whole reason. If we see high infection rates, what are we going to do? Just remain the same, or we're going to maybe do some, oh, hey, there's this trend or that I've seen online that now they're doing this, maybe we should try it. Maybe they'll do a trial run, see how they're doing. They'll do a couple units and see how it's going, and then they may facilitate it on the other units. So QI projects are really good to be monitoring any evidence-based practice changes and updating those things. Attributes of clinical judgment. We are looking at the holistic view. We're not just looking at the patient and treating their symptoms. We're looking at the entire patient, plus we may have to deal with their family as well. Process orientation just means it's interactive when we talk about our model in a second. And then reasoning and interpretation, because nursing care is not linear, right? Every patient is not the same. When a woman comes in with a heart attack, is it the same symptoms as a male? Not all the time. Okay. So that's what you've got to think. A lady that may just be, I just can't get up my steps anymore, I'm just out of breath. That most of the time is how a female comes in with a heart attack, as opposed to a man that has his shoulder pain, his jaw pain, and things. Model of clinical judgment. This is the model we're going to use, and on the other pages you can see the descriptions of each one of these. So first, before we can make any type of clinical judgment, what do we got to do first? What's number one? We got to notice it. We have to come in and notice a change, come in and notice something is wrong because otherwise we think they're fine, right? We have to notice this change. Then we have to interpret it. What's it mean? And then we have to respond. With responding, if it's the right decision, great. Then we can reflect, okay, we did a good job. We can deliver that to our unit. We can say this is what happened, this is what we did, it went great. What if it goes bad? Then we need to go back up to interpreting and respond in a better way. And then we can reflect. We always got to reflect on what could have been better. Debriefing is huge after codes because we want to see what we were deficient in and what we need to do better. And we debrief after simulation too. And it's not to say, point fingers and say, you did that wrong or you should have done this. It's not to do that. It's just, how could I have responded better? You got to look within yourself to see what you need to do better. So again, those are the clinical judgment terms and what they are, so you can just look over those and see. Your context in nursing, so clinical judgment is an essential skill to have for everybody. You don't want to just always think in like a first semester mindset of terms or the definitions of something. You want to now be able to do things and make those judgments. You want to have a deeper understanding of why we're doing something. You learn to recognize patterns. High priorities, so your prioritization with these patients. If you have a patient that's a walkie-talkie and everybody talks about and really they should be discharged that day, you probably want to go in and say, hey, good morning, I'll be back to see you in a little bit, and you go see your more critical patient. Reflective practice, you should always be doing. We'll talk about delegation in a second. I do want to talk about orders right now. So if we have a patient that's had seizures and they need neuro assessment, If it just says neuro assessments, what do you need to know?
How often?
How often? Because sometimes they're 2 hours, sometimes they're 4 hours, but you need to know that. How often? Blood pressure medication. Their blood pressure's 100 over 55, and they say there's no parameters. What do you need to do? Make that call? You make that decision to hold it? You need to call. Be like me. I don't care. I didn't care how bad the doctors hated me. I said, I need parameters. Okay. And they do it for me. But there's a reason why, because that's my license. I don't make that call, and I'm not going to have a cardiologist calling me because I held metoprolol or any other beta blocker for a heart rate of 55 because it's under 60, right? And they say, well, I wanted it to be held if it's under 55. And you're like, oh, well, I missed that one. So you got to make sure that you have the right parameters when you're caring for these patients. Wound orders. Patient has 3 wounds. There's a stage 1, a stage 4. Are they treated the same? If you say yes, they are not. You may have a wound back. Am I going to put a wound back on a stage 1?
No.
No. Maybe on stage 4, but not stage 1. So that is going to be different. So you're going to say, okay, what are my wound orders, right? Because and I think what has helped me is home health. In the hospital, we didn't write out all these charts or care plans, but in home health, you do. So you would have to know, what am I cleansing with? What am I going to cover with? What am I going to secure it with? Tape. What type of tape? So you have to have details. If you are not a detail-oriented person, become one. Because details will be your best friend with nursing. Documentation, everything. How do you write a nurse's note? Do you put your judgment into it? No. You document as you see it. Only your facts, because if you are ever in a position that you say wound care completed and they call you to court for that patient and they say, well, they were supposed to be getting Santil and people were just doing the wet to dry dressing. And you're like, oh no, I swear I did Santil. I know, I remember I did it. Your note doesn't say that. So if you document it, or if you don't document it, guess what? You didn't do it. Because that happens in the court. Another thing, I had a patient that had 2 types of insulin, or maybe 1 type. I can't remember. I just remember I went there. The wife was taking care of the husband, but she was kind of confused a little bit. And I did tell her daughter I didn't think she should be the one taking care of her husband's insulin because he had the short acting and he had 16 units of long acting. But she was getting it confused with the short acting. That could kill him. So those are things that you really need to talk with the patient. You want to verify that this is the insulin, this is the amount, because you could really hurt a patient. And when you're educating them, you want to have those facts. Prioritization. So how do we prioritize? We have a walkie-talkie. He's fine. Maybe one for a stress test. He's good.
Involve ABCs.
You can do that. But then here's another way to think of it. This used to be a question I had on a test, and I don't ever do it anymore. But because it's easier to describe in class, then I can use what we actually talk about in class and prioritize that stuff. So if you have a patient, COPD patient, okay, you have 3 patients. You have 1 COPD patient that his saturation level is 89%. He's fine, he's good. Setting up, a little short of breath, but he has his oxygen on. Then you have a patient that walkie-talkie, been walking around, telling everybody he's leaving, And then you have a third patient that is getting ready to go to a stress test, has active chest pain. Who are you going to see?
Active chest pain.
Because why? Why do some people that look at that saturation level go, holy crap, 89%, we got to do something?
Because of what he's getting ready to do, number 1. Number 2,
he's got active chest pain. COPD, is it normal to be that low? Yeah. It is sad. I mean, sometimes even when you're listening to these patients, there are 0 breath sounds. You're like, But I mean, or they sound really junky. It is really hard, but it's something that you'll learn that they're normals and things like that. Now, a healthy patient, good lung sounds come in with 89% blue lip, things like that. Oh, you better give them back. So you're going to learn about prioritizations, especially with what we're talking about. How do we prioritize? If we don't do something, can it kill them?
Yeah.
That is how you think about prioritization with your patients. Triaging. Just a little, what is it, a 411? That's what people say, 411. So just something to remember when you're doing nursing tests. If you have, as an RN, you have to assess, okay? Reassess, assess. You have to do that. Before you, if somebody comes and says, your patient, da 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 da, are you going to just call the doctor right away?
No.
You got to go in. You have to go in first. Because that doctor's going to say, well, what about how's this or how's that? If you don't know that, he's going to be like, serious. You've got to assess the patient for yourself. Maslow's hierarchy of needs, I'm not going to go over this. This is stuff that you kind of remember from, I'm sure, first semester being your dire needs and then kind of things you come up about. Strategic words. If you can learn this stuff, then it'll help you with your nursing test, in your nursing exam. So, your best, your early, late, essential. Because you may have a test question that you say, well, all of these are good choices. I remember her going over all of these, but what is the best? So then you may think of those ABCs and kind of lining up with those things. Priority order. Like that's a lot of things that we do. We'll put patients in order or in some random order, and then you'll have to put them in order of who is the most, what's it called? Priority. Another thing I do think, and this is a question that I will definitely get answered for you guys. It's not a question, but I'll get it answered for you all. I know last year we had talked about giving points for select all that apply because when the NCLEX, they are now doing that. So I will let you all know if that is what we will be starting to do for you guys, because I know that does help when you select right answers and you just didn't choose one. What that'll do. Delegation. So the process of delegating. What can you delegate? Or what can you not delegate? Let's do that. What can you not delegate?
Assessment.
Nursing assessments, patient teaching.
Remember ad hoc. Ad hoc. Remember that. And something to also tell you guys as students, when you go up on those floors, if you have a blood pressure, like say somebody's blood pressure is really high, and the nurse says, hey, in 30 minutes to 45 minutes, I need you to go back and recheck that blood pressure. You cannot do that without me or without them, because you know why? That's a reassessment. Okay? So RNs are supposed to reassess those things. Not be sending the nursing aides in there, nothing like that. It has to be the nurse. I can go in with you guys and do that. That's no big deal. But just please know what your role is, because I had a nurse yell at one of my nursing students for that one time because she said, well, you were supposed to go reassess that. I said, that's not her job. I said, it's your job, not hers. So please be mindful of that, because you may not put it on as good as somebody else. And I'm not saying you wouldn't, but we just have to make sure that these patients are going to be safe.
No, we don't have a license. I mean,
Right.
I mean, that could be, a life-threatening event that if we're,
Yeah, you can't do that. So that is one thing I think some people get kind of confused about, because I do see it still with nursing assistants. And if anybody's an aide or an extern or anything, you can say, well, I can do it, but you need to be here with me because you got to be the one that reassesses it. Just still kind of know that. Let's see. Okay. Oh, well, we already went over that. Sorry. So here you can kind of see some of the delegation things we do. Another thing as an RN, we may know what yeast is, right? For all the women out there, and I'm sure some of you guys may have seen yeast before. But elderly women sometimes will get it up under their breast. obviously they may get it in their private areas. Please be mindful of the situation that you cannot call a physician and say, hey, my patient has yeast/candidiasis. Don't do that. Say they have some white curdy discharge. You have to explain it. If you document they have yeast, if that ever comes back to court, that falls on you saying that.
I guess they call that a doctor's
Diagnosis.
diagnosis. Yeah.
So you cannot document diagnosis. So write that down, put that in your brain, because when you are documenting, I know it's easy. The patient has yeast. But be mindful of that because you cannot say that. White, curdy, discharge, use whatever descriptions you want to, but don't say rights of delegation. So the right task, the right circumstance, the right person, the right communication, the right supervision. Really, even in a perfect world, and I know it's not perfect, but really with even LPNs and stuff like that, when a nurse is over the LPN for that day, they really should be going back and looking over the documentation and stuff like that to make sure it's complete, because who does that patient fall under? Read this one and tell me the answer. See, why can't they assist somebody with foods and fluids?
They're not licensed assistant personnel.
Can they help with food?
Help.
Can they help feed a patient?
Mm-hmm.
What in this scenario is different? What's this telling you?
Difficulty swallowing.
Difficulty swallowing.
It's part of a feeding program where sometimes the specialist will come and actually feed.
Mm-hmm. So you got to be mindful of that, because we may have some elderly that, sure, I mean, maybe they have Parkinson's, but you'll learn this when we talk about Parkinson's, but they have difficulty swallowing. So that may really need to be the nurse that does that type of. Really, the nurse should know that. But I've seen LPNs, because my grandmother, my great grandmother, had Parkinson's, and she had an aide feeding her, and she had difficulty swallowing. So this really makes me count on that, because I've had family that has gone through this. I've also been on the floor when patient has been difficult to arouse, and I'm obviously, I'm very, very cautious in what I do, not only from my license, but with students, because I obviously do not want to portray bad skills in front of you guys. But this patient was difficulty to arouse. She really needed her medicine, but we were sternum rubbing her and everything. She was not, but she had a medication, and that made her really drowsy anyways. So I went to the nurse and said, we're not doing these meds. Maybe she kind of gets up, wakes up in a little bit. We'll try to give her a bath. And so I walked out. Behind my back as a nurse, this is 3 semesters ago that my nursing student, but she still talks to me about it on Facebook, but she had stayed in there with her. She's like, I just don't feel comfortable about this lady. I'm going to stay in here. I said, that's fine. So I said, in a little bit, we'll give her a bath and see if she kind of wakes up some. So the nurse actually went up behind me and said, your instructor, she's just too careful, and ended up giving her the medicine. Do you know what we heard the entire time that day? She had aspirated it, because they shoved it in her mouth and she did not swallow it. She aspirated it. We ended up giving her a bath that did wake her up and stuff, but please don't do that. Please just be mindful of those things. Because if it was my family that happened to, I would not be happy. So just think of that if it was your family. Cultural competence. What are examples of cultural competence that you have experienced, and what ways do you show cultural competence?
Just somebody that, different culture, like I have some friends who are Native American.
Right, yeah.
I've learned a lot through them about their, preferences or their religious beliefs.
And you learn a lot about my great-grandfather was some portion of Native American, but he really counted on that. But he was alcoholic, and that was something that I learned, and it stuck with me for my whole life, because my grandma would always be so scared everybody in the family would be alcoholics because he was, and that's what we talked about the culture and stuff. So one thing about being sensitive is even just learning their culture. Do you know how respective that is? Like when somebody comes up to them, like Asian Americans, we will speak about Asian Americans in a second, but they use yin and yang, okay, or the hot and cold. Like if they have a baby, I can't remember which one it is because it always confuses me. But once I look it up, I remember it. But with yin and yang, they do like if they have a infection, it's either determined as hot or cold, and then the foods that they intake is the opposite to help them feel better. It's really neat what they do. But that to me would be so respectful if you have an Asian American, and or maybe they were born in the States, they don't really, but you can still ask them, hey, is this a certain disease process that you would eat a certain food? Do you know how like they would just probably be like, oh my goodness, like thank you, because you're respecting them and what their culture is. So African American, prolonged eye contact should be avoided. You guys may notice when I speak to you, I don't look y'all in the eyes because I remember this from my culture in undergrad, and I remember, people saying, I think that's very disrespectful when you look at people in the eyes, and I'm like, oh my gosh, and I'm thinking, I probably felt like I probably disrespected them, and I didn't mean to because growing up, my parents, when they would ask me a question, if I didn't look them in the eyes, what was that?
Yeah,
I'm lying. Where were you, Cassie? It's elementary. My brother and the other hand. I was actually very, very good. My students used to call me Goody Two Shoe.
But I think prolonged eye contact can be seen as a challenge.
It can, yes, it can. So, and that's why they say, to move your eyes and stuff like that. Don't look at them because it's kind of like authoritative. Like even standing over somebody. I'm short, so I'm not really ever standing over somebody. But if I'm standing over you, like a lot of cultures, you would sit in a seat and talk to them because you want to be at the same level, so they don't feel like you are talking at them and down to them. So just be mindful of that. Head nodding. This is huge I feel like any culture, because I get this all the time in home health, is when I'm going over something. This is what I say. Okay. And I'm like, okay, well, you show me. I can't. And so head nodding doesn't always mean like an agreement. Like that would be something that you would say, take some time, think about it, and then let us know. Health risk, sickle cell. That is huge to remember. Even lactose intolerance. A lot of the patients, when we take care of them, we want to know these things. Asian Americans, eye contact can be viewed as disrespectful. I had a few Asian Americans when I took care in Illinois, and so I'll kind of always remember that. And like, but then I feel like it's disrespectful not to look at people, so I'm trying to juggle both at the same time. Men have power and authority in these cultures, so when a man comes with them, they may be the ones making the decisions. But again, no judgment. You deal with the culture. Illness, again, may be viewed as an imbalance of the yin and yang. So you're going to see those food and what they decide, what they want to eat, and things like that. So be mindful of that. Health risk, thalassemia, that is one of the biggest ones that I remember learning about that has not changed in 13 years since I've been out of school. So just, remember those things. Amish, known for their simple way of living. Christian religious values. Why do they have fewer risk factors? Why do you think?
They grow their own food. I mean, they're probably not ingesting as much, processed stuff.
Yes. So that is why you see those fewer risk factors, because we went to an Amish community, and my daughter thought it was so neat, but all these little kids were outside working, digging, and doing that. And so really, you got to be mindful of how is their way of living. They really don't have a lot of outside sources. They do everything like on their ground. They usually speak German, Pennsylvania, Dutch. A lot of their churches languages are German, refusal of immunization risk, so we may have a lot of them that will not do the vaccines. The other thing I want to bring up is the Jehovah Witnesses. What do you know about Jehovah Witnesses? Yes. So even if they are hemorrhaging and dying, do you respect that?
Yeah.
You have to respect that. Hispanic Americans. Primary languages can be English and Spanish. They're very verbally expressive. They're very fun. Avoid eye contact out of respect. That is one thing I read in that book, and I don't agree with because all of my patients wanted direct eye contact. They said, I asked them because I was close to them, and I said, do you find it like disrespectful if I was looking at you? I'd rather you look at me than say. So that's one thing. A large extended family network. What do we see in this patient population that you always hear of? Tuberculosis. Why?
They all live together.
They all live together. Their entire family. My girl I worked with, that I became like her family became my family. She lived. It was her mom, her mom's siblings, and then it was her son, her grandparents, and then her great grandparents were all in one household. So a lot of times we do see TB. With TB and OB here, we don't really generally test people for TB. Just when there are OB patients up there, we test every single patient for TB. So that was a very different, like from going from one place to another, and neat to see why we do that. Health risk, hypertension, diabetes, obesity, heart disease is what we see. Native Americans, you can kind of read over these. Elders are honored. Family oriented. You can see some of the health risks with alcoholism, diabetes, heart disease, TB. Again, living in those areas and things like that. What else what else do you think you've seen with your friends with Native Americans? Do they do
you
the
got heart
shaman?
disease, but high hypertension.
Yeah. What about shaman? Do they all go to the shaman?
My friend's a shaman.
Yeah, see? So that may be one thing that you see is the shaman. Instead of going to like a physician, they do like the shaman and things. So those are things to be mindful of.
We share shall we say natural remedies.
Yeah.
She's always sharing natural remedies.
And that's the one thing that a lot of them do is like the herbs and things. So that's important to remember. And why is that really important? If a patient, Native American, goes to the hospital, what do we want to know? We want to know that
because they can affect
medicine. Yes. So that is one reason we always we've asked everybody now because even I know a lot of my friends have went to like a lot of herb treatments, so it's really important to know those things. Like maybe they get hot flashes and things just because if a physician wants to put them on something, it may interact. So you want to ask every patient about that. White Americans, Caucasians, so eye contact is trustworthy. So again, if I looked left or right, I was lying apparently. Handshakes is a way of formal greeting. That has gone out the window since COVID. I feel like now everybody's just like, how you doing? Like nobody really does the, I don't know. I'll automatically reach out and look, kidding, because we don't do that anymore. So handshakes used to be a sign of formal greeting. Health risk. Oh yeah, I'm a hugger, and I can't be a hugger.
Me too.
So yeah, so hugging, anything like that that you've noticed about families. Cancer, heart disease, diabetes, obesity, hypertension. So you can kind of see some similarities with cultures. I think right now, heart disease, diabetes, things, all the processed foods we have, not eat them too. I do think a lot of the foods that we now take in has a lot of effects on the stuff. Lab work. So I used to do my own. I was never that nice like Miss Hackney was and give you all. I mean, she went through the book. She went through the book and looked up labs for you guys for all the classes. That was really nice of her. I would just do a sheet and just say I do it when we talk about it. So one thing to really do is when we are going over especially oncology, I'll talk a lot about different labs. When I bring that up, what I want you all to do is go to that and mark it so you know those labs for your test. You want to know the normal values because, again, like Ms. Huffman said, I'm not going to sit here and say, is this normal? I'm going to give you like all these labs and then say, what do you need to call about? And you're going to have to say which ones are important that you need to notify the physician about. Maybe it'll be a question like, what do you need to do about it? And what's really nice about this semester is I've included simulation, like Ms. Hoffman said, every single week. You know why? I used to do the same simulation. We would do it twice a time with me. Like, so you would come with me and I'd do it 2 simulations with you. The same simulation each time with each group. This group, you will never have the same simulation because I'm going to do a simulation that's related to something that we have gone over. And there's a reason why, is because whenever I was doing all these professional educations, with just what we need to do better as nursing educators, one of the top reasons why they are saying new nurses are deficient in clinical judgment is because they don't have enough hands-on experience. So what can we do better is to facilitate that learning each time we go over something. Let's use the simulation lab. Let's give you the content also in the lab and see if that makes a difference. So each rotation, like Tuesday's group next week, not this week, but the following week, if you're with me, we'll do something that is on today/Wednesday's lecture, and then so forth each time. So you may think that, well, that's not fair if they get to do that. How's the rest of the class going to get it? Easy. Wednesday after the Tuesday that you get it, Tuesday after you get done in simulation, you will sit together as a group. You can come up with a PowerPoint, or you can come up just with a document. If you're a great artist, draw on a poster board. Bring it in for that Wednesday that you all, and it's going to be in your clinical group. So you all can discuss how do we want to deliver that in class. Because you can act it out at the end of class, each group will tell about their scenario. And that way you all get what each group got to do. So that should help with facilitating some learning. But again, just know the normal labs. And it's not just knowing normal labs. If you know the normal labs, then you want to know, obviously, the abnormal, right? That something needs to be done about it. Also, in the clinical, I will just kind of say, this is the end of class, so we don't go over anything else. But in clinical, when you're looking at certain medications, if you know a medication may affect something, say LASIK affects what? So what electrolytes? So like your potassium, all those things. So it's important for you to look at those. Why? What if they're not on potassium? What happens to your potassium levels? It drops. Yeah. So then you would need to tell me that. Because we've actually had students that would tell the nurse and they would say, oh, thank you for noticing that, and then call the physician and order that because it wasn't ordered. It should have been usually like potassium, but somebody didn't order it. Those are really important tasks because then when you're in 4th semester and your first year out of nursing school, you're going to know these things and what to do with it. Do y'all have any questions? Like Ms. Hoffman said, do not go ahead and look over this stuff. I mean, a lot of this stuff's going to really push your culture stuff. You want to look at your ethical principles. You want to go ahead and look at because then Wednesday, all you got to do is add that content onto the day. I will tell you about a study from Harvard that they said if you write your notes, if you write your notes, if you go over your notes the day of, the day after, you are 90% more of being able to retain that information than if you waited 3 or 4 days. So if you do it today, you do it tomorrow, then you add on Wednesdays, you won't have trouble in this course, but if you delay yourself with studying, you'll get behind. I want to go get Ms. Hackney so she can divide you guys up in your groups. Yep. I live in Lake in the Hills. West suburbs. West Chicago. Oh, you live in South.
Chilly in here. I
chilly.
Well, I put my sleeves down. I was hot earlier, but then I get cold. This is a weird room.
It is a weird room. Like, I was doing good. I felt warm, content. Now, like, a breeze came through, and I'm like,